You know, we rarely stop to marvel at it, but think about it. Your body has this incredible ability to, well, patch itself up after an injury. Even a simple paper cut sets off this whole cascade of events. It seems pretty straightforward, right? But when you look closer, wound healing is surprisingly complex.
Absolutely. It really is. What looks like a simple fix is actually this beautifully orchestrated biological ballet. And that's exactly what we're getting into in this deep dive. We're using wound care essentials, practice principles, specifically that chapter on acute and chronic wound healing, to really understand, what's actually happening under the skin.
Okay, so our goal today is to unpack this amazing repair system. We'll follow the journey right from the injury itself, through all the stages up to the scar forming. And we'll also look at why some wounds heal fast and, well, others seem to get stuck. Plus, the hidden role of these things called biofilms and why getting the wound environment right is so critical.
Exactly. Think of this as our detailed tour. We want to give you a much deeper appreciation for this really fundamental biological process.
Yeah.
And maybe shed some light on why sometimes the body's repair shop faces challenges.
All right, let's jump right in. Think about that paper cut again. Their source material walks us through how these acute wounds normally heal in four main phases. But what's really key to understand, I think, is that these aren't like separate, distinct steps. It's more of a continuous flow, isn't it, with phases overlapping.
That's such a crucial point, yeah. It's not rigid step one, step two. It's dynamic. So the first phase, hemostasis, that's the body's immediate reaction. It's all about stopping the bleed. When tissue gets injured, blood vessels break, you get hemorrhage. This exposes the blood to the surrounding tissue, and that triggers platelets in the blood to clump together. They get activated.
Right, like tiny little emergency workers rushing in to plug the leak. And this platelet action, it kicks off something called factor 12. What's that about?
Factor 12, yeah. It sets off a chain reaction, kind of like dominoes falling. And that ultimately leads to a fibrin clot forming. So the main goal right there is just stop the bleeding, create a temporary plug.
Got it. Plugging the leak is job number one. Okay, so what happens once the bleeding's stopped?
Well, almost at the same time, another process called fibrinolysis starts up. That's where the fibrin clot begins to break down. Just a little. Think of it like the body saying, okay, link plugged, but let's not make this plug a permanent roadblock. Fibrinolysis gently dissolves just enough of the clot so that other healing cells can actually get into the area. It stops the clot getting too big and blocking the next stage.
Okay, so the plug is there, but it's already being prepped for what comes next. What is next?
That takes us to the inflammatory phase. As that clot starts to break down a bit, the tiny blood vessels nearby, the capillaries, they dilate, they get wider and more porous. This lets fluid and immune cells seep into the injured spot. And at the same time, a key part of your immune system, the complement system, gets switched on. One bit of that, C3b, helps certain immune cells, neutrophils, grab onto bacteria and basically eat them. That's opsonization and phagocytosis.
So the body isn't just stopping bleeding, it's immediately on defense against potential infection. And our source mentions loads of these messenger molecules, cytokines, growth factors. Sounds like a really busy microscopic scene.
Oh, it really is. These molecules, growth factors, interleukins, tumor necrosis factors, interferons, they're collectively called cytokines. They're like this complex language the body uses to coordinate everything. Different cells produce some of those platelets we mentioned, fibroblasts, monocytes, macrophages, endothelial cells. Right after the injury, platelets release key ones like PDGF, TGF, EGF. They act like signal flares, basically attracting neutrophils first, and then later other important immune cells called macrophages to the site.
So these cytokines are basically shouting, hey, damage over here, need backup.
Yeah.
And they don't just call cells in, they tell them what to do when they arrive, right? Like multiply, move around, build new stuff, manage the inflammation.
Precisely. And what's really fascinating is how many signals are flying around at once. These cytokines, they're like this intricate language, constantly fine-tuning the healing based on what's needed right then. They don't just work alone either. Their effects can add up, they can boost each other, or sometimes even cancel each other out. It's a really, really finely tuned system.
Okay, so after the initial cleanup and all that signaling, the body shifts into the proliferation or repair phase. This sounds like where the main construction work happens.
That's a good way to put it, yeah. This phase usually kicks off around day 3, and it can last for several weeks. The big event here is forming granulation tissue. That's essentially the scaffolding for the new tissue. It's a matrix made of stuff like fibrin, fibronectin, different collagens, and other structural molecules, and the key builders. Specialized cells called fibroblasts. They move into the wound, start multiplying like crazy, usually peaking around day 7.
And these fibroblasts, they're the ones churning out the building materials, especially that crucial protein, collagen. Our source mentions that initially it's a weaker type of collagen. Is that why there's still a risk of the wound popping open? What's that term again?
Wound dehiscence, yeah. And if it's a deeper surgical wound and organs push through, that's evisceration. It really highlights why patients need to be careful, follow advice in those early weeks after an injury or surgery. But back to that granulation tissue, it's a mix of cells, those fibroblasts, some lingering inflammatory cells, and importantly, tiny new blood vessels. That process is angiogenesis.
Angiogenesis, growing new blood vessels. Makes sense. The new tissue needs oxygen and nutrients to grow properly. How does that actually work?
Well, the cells lining the existing blood vessels, vascular endothelial cells, they start sending out little sprouts. They break down the surrounding tissue a bit to kind of invade the wound space and form new capillary buds. These sprouts then link up, creating loops and a network for blood to flow. At the same time, skin cells right at the edges of the wound start migrating across this temporary matrix to close the surface. They keep moving until they bump into other skin cells, and that contact tells them to stop. It's called contact inhibition.
So it's like the skin cells are crawling across the wound bed, pulling the edges together. And the source also mentions wound contraction. That sounds like another way the body shrinks the wound.
Exactly. That usually starts around day 5. Specific types of fibroblasts, called myofibroblasts, are the main players here. There are a couple of ideas on how it works. One is that these myofibroblasts have internal structures, like tiny muscles, that contract and pull on the collagen fibers, drawing the edges closer. Another idea is that fibroblasts just exert pulling forces on the surrounding matrix proteins, like wheels gripping a surface, gradually bringing the edges together. Contraction is especially important in bigger wounds where you've lost a lot of tissue.
And for us as patients, say we have a wound left open to heal secondary intention. You called it, what are the good signs we should look for during this proliferation phase?
Yeah, good question. You should look for healthy pink tissue developing in the wound bed. That's the granulation tissue. You should also see signs of new tissue growing in from the wound edges. And importantly, the wound should be gradually getting smaller over time. Those are all positive signs that the body's actively repairing itself.
Okay, so the wound is closed, or at least much smaller. But the journey's not quite done, is it? That brings us to the final phase, maturation and remodeling.
That's right. This is the long haul phase. Starts around day 7, but can last a year, maybe even longer. Initially, that scaffold, the new tissue matrix, is made of things like fibronectin and hyaluronic acid. It's like a temporary template. Then, more permanent collagen gets laid down. Over time, collagen becomes the main component, and it starts organizing into stronger, more structured bundles. This increases the overall tensile strength of the healed tissue.
But even with all that work, our source points out that healed wounds never quite get back the full strength of the original skin. That's really important to remember, isn't it? To prevent re-injury. And this remodeling involves both building up and breaking down collagen, right? A balancing act.
Precisely. Specialized enzymes called collagenases handle the breakdown, making sure the new collagen fibers line up properly and get organized. This phase also sees fewer cells and blood vessels in the area. And those myofibroblasts, the ones that did the contracting, they eventually undergo programmed cell death apoptosis. The end result is a scar. It's basically a less vascular, less cellular patch of mostly collagen that restores continuity, but isn't quite as strong as the original skin.
And for patients, what should they expect to see with the scar over time? Does it change?
Oh, definitely. Initially, a scar might look quite red and might be raised. But over many months, sometimes even up to a couple of years, it usually becomes paler and flatter. Keeping the scar moisturized can actually help with the texture and the overall look of the tissue. If a scar stays really raised or swollen, though, that could be a sign of abnormal healing, like hypertrophic or keloid scarring. That's worth getting checked out by a healthcare professional.
Now, throughout this whole discussion of the phases, our source keeps bringing up these enzymes, matrix metalloproteinases, MMPs. What's our exact role in all this?
MMPs. They're like the body's tiny demolition and construction crew, rolled into one. They're enzymes that break down proteins, and they play crucial roles in all phases of healing. During inflammation, they help clear out damaged structural proteins, making way for new stuff and letting cells move around freely. They're also vital for angiogenesis, helping break down barriers so those new vessel sprouts can form. And even in remodeling, they help with tissue contraction by myofibroblasts. It's a really delicate balance, though. Their activity is tightly controlled by natural inhibitors called TIMPs.
Okay, so MMPs are essential for clearing the path and helping rebuild, but they need careful management so things don't go haywire. Right, we've got a good picture now of how a typical acute wound heals. But what happens when this process gets derailed and we end up with a chronic wound? What are the key differences there?
That's a really important distinction to make. Yeah. While there isn't one single universally agreed upon definition, acute wounds generally follow that predictable, timely healing path we just described. They often come from surgery or trauma, usually heal by primary intention, where the edges are brought together easily. Chronic wounds, though, they deviate from that sequence. They take much longer to heal, usually heal by secondary intention, and they're very often linked to some underlying medical issue.
And what sort of time frame makes a wound chronic? Is there a general rule of thumb?
A common benchmark is a wound that shows no real signs of healing within about 4 weeks, or one that just isn't healing in the expected time frame, even with standard medical care. You might hear lots of different terms used for these wounds: delayed healing, non-healing, complex, recalcitrant, stalled, hard to heal. Actually, teaching patients these terms can sometimes help manage expectations about the healing journey.
So it's not just about time. There are actual biological differences happening in chronic wounds, aren't there? The source mentions something about the wound fluid itself affecting cells.
Yes, that's a critical point. Research shows the fluid they exudate in chronic wounds can actually inhibit the growth and function of fibroblasts, those essential builder cells. It suggests the whole environment inside a chronic wound is out of balance, actively working against healing. Another huge factor seems to be prolonged inflammation. In chronic wounds, you often find this persistent army of inflammatory cells, like neutrophils. They keep pumping out pro-inflammatory cytokines, keeping the inflammation cycle going. And they also release tissue-damaging enzymes, proteinases, that can break down any new tissue that tries to form.
Wow, so it's like the body's initial alarm system gets stuck on full blast and ends up causing more damage. What else can push a wound towards becoming chronic?
Several things can tip the balance. Repeated small injuries to the same spot, something called ischemic reperfusion injury, where blood flow gets cut off then restored, which can paradoxically cause damage. Low-level bacterial contamination that maybe isn't a full-blown infection but still disrupts things, or even having foreign material stuck in the wound. Also, that process of skin cells migrating across to close the wound, re-epithelialization, that can be much harder in deep chronic wounds because the normal skin structures that help guide those cells are often gone, and the cells struggle to move across the wound bed.
And what are some common types of wounds that often end up becoming chronic?
Well, we frequently see chronicity in venous leg ulcers, pressure injuries, what used to be called pressure ulcers or bed sores, diabetic foot ulcers, arterial ulcers, and sometimes surgical wounds that get infected, or traumatic wounds that were heavily contaminated from the start.
Okay, so we have the normal process and what goes wrong in chronic wounds. But what about factors within the person themselves that can affect healing? Our source lists quite a few host factors.
Absolutely. These are individual characteristics that can really impact the body's repairability. They include things like, well, age, any other medical conditions someone has, their disease burden, sex, race, and ethnicity. Oh, we need more research there.
Yeah.
Also, any weaknesses in the immune system, medications they're taking, BMI, nutritional status, and lifestyle factors like smoking.
Let's dig into a couple of those. Age, for example.
Yeah.
How does getting older affect wound healing?
Aging can impact healing in a few ways. Older people tend to have higher levels of those pro-inflammatory cytokines we talked about, but kind of paradoxically, they might also have lower levels of some key growth factors needed for repair. Their fibroblasts, those builder cells, can also become less responsive to growth factor signals. Plus, you might see increased activity of those MMP enzymes that break down tissue, leading to more degradation of collagen and other structural bits.
So it's like the body's repair crew gets a bit less efficient with age. What about other health conditions, comorbidities?
Oh, comorbidities can definitely mess with the inflammatory response, which, as we've seen, is often central to chronic wounds. Conditions like diabetes, poor vein circulation, venous insufficiency, heart failure, obesity, they can all disrupt normal inflammation. Obesity, for instance, is often linked to a state of sort of low-grade chronic inflammation throughout the body. And then you have the treatments for these conditions, the medications people are on, maybe developing antibiotic resistance. That can all complicate healing further. Plus, conditions driven by inflammation itself, like vasculitis or rheumatoid arthritis, can hinder healing by releasing more pro-inflammatory cytokines. There's a blood test, C-reactive protein, or CRP, that can sometimes give a hint about the overall level of inflammation in the body.
In a weakened immune system. That seems like an obvious hindrance to healing.
Yes, absolutely. If the immune system isn't working properly, the body's less able to fight off infection in the wound, which definitely delays healing. For example, people with HIV/AIDS who have low counts of certain immune cells, CD4 plus T cells, often heal much more slowly. Poor blood circulation, common in diabetes and venous ulcers, is another big one. Oxygen is absolutely essential for making collagen and growing new tissue. And finally, poor nutrition and hydration. They can really impair healing by limiting the building blocks and fluids needed for skin cell growth and collagen production. Even some medications can contribute to nutrient deficiencies.
It's quite sobering, really, how many different internal things can affect something as basic as healing. Now, there's another factor our source really highlights as a major barrier: biofilms. These sound like a real challenge.
They really are, yeah. Bacterial biofilms are essentially like organized communities of bacteria. They stick together and create this protective, slimy layer around themselves made of sugars and proteins. These communities can be one type of bacteria or, more often, a mix. What makes them so problematic in wounds is that they trigger this persistent, chronic inflammatory response. The body sends in neutrophils and macrophages to attack, but these cells end up releasing high levels of damaging substances, ROS and proteases, that can actually harm the surrounding healthy tissue and slow down healing.
So the body's trying to fight the infection, but the bacteria's strategy, this biofilm, turns the body's own defenses against itself, in a way. What makes them so tough to get rid of?
Several things. That protective matrix acts like a shield, making it hard for antibiotics and antiseptics to actually get through and reach all the bacteria, especially the ones deep inside. Plus, some bacteria within the biofilm can go dormant, and many antibiotics only work on actively growing bacteria. Certain conditions also make biofilm formation more likely, like a weakened immune system, poor blood supply, dead tissue in the wound, or poor nutrition.
And how do you even know if a biofilm is there? It sounds like they might be hard to spot.
They can be tricky, yeah. It's hard to tell them apart just by looking from slough, that yellowish, gooey stuff you often see. Biofilms tend to look a bit more gel-like and shiny, while slough is usually more opaque, maybe thicker. But actually, seeing slough can sometimes be a clue for biofilm, because the inflammation triggered by the biofilm leads to more fluid and slough production. Standard lab tests for bacteria. They're often not great for detecting biofilm bacteria because they're designed for free-floating, single bacteria, not these complex attached communities. Right now, specialized microscopy is the most reliable way to confirm them, and studies show biofilms are incredibly common in chronic wounds. Some estimates put it at a really high percentage, like maybe 60% or even up to 80% in some analyses.
That's a worryingly high number. So if standard antibiotics and antiseptics struggle against biofilms, how do you manage them?
The approach is often called biofilm-based wound care. It really focuses on physically removing the biofilm through things like debridement and really thorough cleansing, and then using dressings that help block new bacteria from sticking and also kill any remaining ones. Patient compliance is super important here because biofilms can reform pretty quickly. If a wound just isn't responding to antibiotics or antiseptics, that's often a big red flag for biofilm. Some specialized antimicrobial dressings, like ones with time-release silver or Dexomer iodine, seem to show better results against mature biofilms in lab and animal studies. But, and this is key, just debriding, just removing the biofilm usually isn't enough on its own. You really need to combine it with topical antiseptics to help stop it coming right back. There's also this strategy some use like a step-down, then step-up approach. Aggressively remove the biofilm first, then maybe less frequent debridement plus dressings for any free-floating bacteria left. And then once the wound bed looks much better, you might move on to more advanced therapies.
This really drives home how vital it is to prepare the wound bed properly, creating the best possible environment for healing. Our source introduces a really helpful acronym for this: TIME. Can you walk us through what TIME stands for?
Absolutely. Yeah, TIME is a well-known framework. Wound care experts developed it as a systematic way to approach preparing the wound bed, especially for those chronic wounds healing by secondary intention. It stands for T, tissue; I, infection inflammation; M, moisture balance; and E, edge of wound. The main idea is that you need to look at and address all four of these areas every single time you assess the wound.
Oh, okay, let's break that down. T is for tissue. What's involved there?
Tissue management is all about spotting and removing any tissue that isn't healthy or any foreign stuff in the wound bed. That includes necrotic or dead tissue, maybe bits of old dressing, that slough we mentioned, excessive wound fluid or exudate, and even the biofilm itself. There have been advances in how we remove this non-viable tissue, like using negative pressure wound therapy in specific ways, or a technique called hydrosurgery.
Okay. And I is for infection inflammation. How does time address that?
This means carefully assessing the wound to see if there's an infection. If so, do we need topical antiseptics, systemic antibiotics? It also involves managing any inflammation that seems inappropriate or is just going on too long, inflammation that's not helping the healing process or is excessive. We think about that whole spectrum, from just bacterial contamination right up to a full infection, always keeping potential biofilms in mind. With worries about antibiotic resistance growing, there's definitely been a shift back towards using topical antiseptics more. We also use tools like negative pressure wound therapy, dressings with antiseptics like silver or PHMB, and newer molecular diagnostics are helping us understand what's really going on microbiologically.
M is for moisture balance. That sounds pretty intuitive.
It's crucial, though, yeah. Both too much moisture, too much exudate, and too little can seriously slow down healing. So this part of time focuses on assessing the amount and type of fluid coming from the wound, and then choosing the right dressings to keep things at an optimal moisture level, while also protecting the skin around the wound, the peri-wound skin.
Right. And finally, E is for edge of wound. What are we looking for there?
Here, we're checking if the wound edges are actually moving inwards, closing the gap like they should, or if they seem stalled. Or sometimes, are they tunneling under the surface? That's called undermining. We also look closely at the condition of the skin right around the wound edge. If the edges aren't advancing, we might need to think about different treatments to try and kickstart that epithelial cell growth. It's important to remember, time is just one piece of the puzzle. It's part of a bigger holistic patient evaluation. But it does provide a really useful structure for talking with patients about their wound and the treatment goals.
Yeah, that time framework sounds like a really practical, systematic way to tackle these complex wound issues. Now, our source also touches on something that might not be the first thing you think of with physical wounds. The symptoms, and even clusters of symptoms that people with chronic wounds often experience.
This is a really important area, and it's getting more attention now. There's actually significant communication between the brain and the immune system. Immune molecules, like those cytokines we discussed, can directly affect things like pain perception, our thinking, even our behavior. So people with chronic illnesses, including chronic wounds, very often experience psychological distress and what we sometimes call sickness behaviors like fatigue, feeling depressed, anxiety.
So it's not just the physical wound itself, it's impacting the person's whole well-being. What are some common symptoms that tend to cluster together?
Yet, many people with chronic wounds deal with multiple symptoms concurrently. Often it's pain, this persistent feeling of exhaustion or fatigue, anxiety, depression, and trouble sleeping. Pain especially can be a huge problem. It affects their ability to do daily things, stick with their treatment plan, and just generally tanks their quality of life. And unfortunately, this pain often isn't managed well enough, which can actually delay healing even further.
And it sounds like these symptoms can kind of feed off each other, too.
They absolutely can. There's evidence suggesting that changes in thinking ability, fatigue, depression, anxiety, they often all show up together in people with chronic wounds and pain. Chronic pain and these psychological symptoms can even make it harder to think clearly. It's also been noted that depression seems to be associated with slower wound healing. This whole area, understanding how these symptoms connect in chronic wounds, really emphasizes why we need a more comprehensive, patient-focused approach to care.
To really bring all this together, our source gives us a detailed patient scenario, Mrs. A. Can you walk us through her story and how her wound was handled, maybe pointing out some of the principles we've talked about?
Certainly. Yeah, Mrs. A was 72 years old. She smoked, had COPD, ischemic heart disease, and was on several meds, including blood thinners and oral steroids. She had a fall, developed an infected collection of blood, a hematoma on her leg. Initially, she had a chest infection, so care focused on that. But eventually, that infected hematoma needed surgical drainage, which created an acute but infected wound.
Okay, so right off the bat, Mrs. A had several of those host factors we know can make healing tricky: her age, smoking, COPD, steroids, plus the infection.
Exactly, all those things. After the surgery, they initially used negative pressure wound therapy. They identified the specific bacteria causing the infection and gave her antibiotics. The infection seemed to get better, but her skin was quite fragile, probably from the steroids, and she got some skin damage around the wound from the negative pressure dressing. So they stopped that therapy and switched to a highly absorbent dressing, a hydrofiber dressing, to manage the drainage. Despite that, after about 5 weeks, the wound just stopped healing. It wasn't getting smaller, and it developed this layer of kind of gelatinous slue on the surface. At that point, it was classified as chronic, non-healing, and they suspected a high bacterial load, possibly a biofilm.
Ah, so even though the initial infection was treated, the wound stalled out, fitting that definition of chronic we discussed. What did they do next to try and get it moving again?
Right. The team decided to debride the wound, that clean out that non-viable tissue and potential biofilm. They used a local anesthetic cream to make it more comfortable for her. Then, at each dressing change, they cleansed the wound with a solution containing PHMB, an antiseptic, and applied a highly absorbent antimicrobial dressing with silver. And after those interventions, the wound finally started showing positive signs again. New skin started growing from the edges, the wound began to contract. Eventually, they were able to stop the antimicrobial dressings, and the wound continued to heal up.
So, in Mrs. A's case, it really seems like tackling that potential biofilm with debridement and antimicrobials, plus managing the wound environment carefully, was a key to restarting healing after it got stuck. It's a great real-world example of applying those time principles, isn't it?
It really is. Her case perfectly highlights the complexities you can face, especially with patients who have multiple health issues and risk factors. It also just underscores how vital it is to keep assessing the wound and be ready to adapt the treatment plan based on how it's responding or not responding.
Well, this has been a truly insightful deep dive into the, well, fascinating and really complex world of wound healing. It's certainly much more intricate than most of us probably ever stop to think about.
Indeed it is. We see it's this dynamic multi-stage process, but it can be affected by a whole host of factors, sometimes leading to these difficult chronic wounds. Having a solid grasp of these complexities right from the cells up to systemic health and those challenging biofilms, it's just absolutely essential for managing wounds effectively.
So we hope that you, our listener, now have a much greater appreciation for the remarkable processes your body kicks off when it needs to repair itself, and the many different factors that can either help that along or, unfortunately, hinder it.
And maybe this leaves us with a final thought to ponder. You consider this incredibly delicate balance within the wound environment. And as our understanding of things like biofilms and the body's intricate immune response keeps growing, what potential does this knowledge hold for the future? Could we see even more targeted, maybe more personalized wound care therapies emerging, ones that truly work with the body's own healing power? It certainly gives you something to think about, doesn't it? The future of wound management.